Well, it's so awesome to see everyone here. And today what we're going to do is we're going to talk about, I'm going to do 2 talks. And in between, Dr. Lori Madden is going to present some of her work that she's done with her PhD. So the first part of targeted temperature management that I'm going to do is really sort of set the groundwork. So some of the background material, things to think about when we are managing our patients. A couple of disclaimers. I am on the Speakers Bureau for BARD, and this is not intended to be nor implied that it's medical advice. It's really just to give you some general education and information. I am also a clinical application specialist for another small company that does data integration. So your talk on multimodality monitoring, it's how to take all that kind of stuff and put it into one place to manage you. I'm also clinical faculty at the University of Washington, and I am a stockholder in Integra Life Sciences. So we're going to talk about the application of targeted temperature management on not just brain. It's not just there where it's been, but in many applications. So it's also been used hypothermia in the spinal cord patient. But so I'm going to try to set sort of the stage of using why we would want to use targeted temperature management and what it is. So when we have an injury, regardless of what it is, there is a series of events that is activated. And this cascade that we all know of as secondary brain injury worsens the patient's neurologic injury. And there are a few things in particular we're going to talk about as we talk about where targeted temperature management comes in. And that's the events that occur over here with the ischemia and the potential mitochondrial failure, trying to prevent these kinds of things and inflammation. And we know all of these events may lead to increased intracranial pressure, again, worsening the patient's potential outcome. When we talk specifically about ischemic and anoxic type of injuries, it's described as 3 phases of injury. The first phase of the injury starts out with that energy failure, depolarization of the cell membrane, release of excitatory amino acids, flux of calcium into the cell, overloading it. And if we have irreversible injury, the ischemia is prolonged, it sets the stage for more and more injury, and especially if we eventually reperfuse that patient. So the second phase is that reperfusion phase. First phase is amplified. We have a resumption of the oxidative phosphorylation because we have now added oxygen back into the system, and this is where we start to see things like the oxygen free radicals or reactive oxygen species that are produced. The mitochondria now starts to fail because of this flux of calcium into the cell. So the calcium is not supposed to be in the cell. And along with all of this, we have mitochondrial permeability, and it's open to the triggering of these cell death signals, so apoptosis. The third phase is a delayed reperfusion, and we're characterized by further neuronal injury as a result of the calcium overload, and the activation of pathologic proteases, altered gene expression, and inflammation. Now, these things I want you to kind of keep in the back of your mind, because as we start talking about temperature management, there are very specific things that the temperature management is going to help to modulate. So what do we know? Well, first off, we know that fever is bad for the brain. It worsens outcome. That's been pretty well established. We also know that temperature management can moderate the impact of secondary injury. So what I had just said, so it's one of the reasons that we're interested in this. So when we talk about targeted temperature management, there's basically 2 things that we're talking about. It's the prevention and the treatment of fever, And it's also the use of hypothermia and when to use it and how to use it. So there's been lots of research that have shown that a lot of the cell dysfunction that occurs, the cellular mechanisms, including the endothelial dysfunction, the production of those reactive oxygen species, and apoptosis, are temperature dependent. So again, leading us to why is this important? There's a lot of good basic science research telling us that targeted temperature management should work. However, the efficacy in human trials is variable, and there's limited information. So depending on the disease, we'll tell you whether we have good information or we still think this is the right way to go. So what do we know? So the first thing I want to do is I want you to be able to understand how heat is generated. So that's thermogenesis, and then what that does to the brain. So we know that thermogenesis is the production of heat from metabolism. And that production of heat comes from ATP. And when do we have ATP? Well, we see the most ATP during aerobic metabolism and only a little bit ATP production in anaerobic metabolism. So it's that ATP that is the source of energy and therefore leading to heat. There are a number of organs that can produce this energy and heat, the brain being one of them. It can produce its own energy. But there are many organs that can produce heat, but the most common ones and the biggest producers are the thyroid, related to the thyroid hormone, skeletal muscle, liver, and the splenic organs. The nervous system is then what regulates that heat to maintain the body at a constant temperature. So the brain is the master regulator. Now, another thing that generates heat is inflammation. We all kind of know this, but when we think about it in relationship to our temperature, we have an external source of stimuli. That can be an injury that creates inflammation, or it can be an infection. That stimulus activates our immune system. And it's the immune system and our inflammatory mediators that are what are going to stimulate the brain, in particular PGE2. And PGE2 is going to activate the warming sensor neurons in the anterior hypothalamus, the preoptic neurons. Okay? And when they're stimulated, it can change the patient's temperature. It can reset our thermostat. So how does this work? Well, if we think about what happens when we're hot. So you guys, we're here in nice hot weather, and particularly if it's a really hot day and then you're outside trying to do some activities. How do you cool yourself down? Well, what's going to happen is your body is going to send a message to the hypothalamus to say, I'm hot. We're going to dilate all our peripheral vessels in order to allow heat to escape, the radiation, and we're going to sweat. The problem is if you don't sweat, you're not going to cool. It's going to affect your ability to cool. So that's evaporation. Our temperature is maintained. Now, if I'm cold, same thing. Body's going to send the signal to the hypothalamus. But in this case, we're going to vasoconstrict. In fact, we're going to vasoconstrict everything in the periphery to shunt the blood back into the core in order to maintain perfusion and warmth in our core. I always think of this in the winter. If any of you are skiing or you go out for outdoor activities when it's cold outside, my hands and feet are cold. And no matter what I do, if my hands and feet are cold, I'm cold. I feel cold, right? So The other way that we're going to try to warm ourselves is our tension in our skeletal muscles. We're going to feel cold. We may shiver, and that's going to help to generate heat. So the body temperature represents a balance between the heat produced and the heat lost. And we do a pretty good job of generating, as long as we maintain that balance, we have a pretty stable body temperature. But the problem is that all of our body isn't going to have the same temperature necessarily. So this is going to come back. I want you to remember this last line there when we talk about where do we take our temperatures. To be representative of the core, the real temperature we want to know about. So we all know that normal temperature is somewhere around 37, and with a range of 36.5 to 37.5, and that it's highest during the day. Our temperature starts to rise early in the morning, about 6 in the morning. Mine didn't do that. I think it started last night about 3, when it's supposed to be at the lowest. So we know that there are changes. So those of you who work night shift, you may see, unless there is a problem, that the temperature is a little bit lower if you were mapping this out in a graph. And it changes throughout the day depending on our activities. So I'm thinking everybody's body temperature is probably a little lower on the low side now because you've been sitting around. Although it may be a little bit higher than an hour or so ago because you just ate. So another thing we want to do is make sure that we're using the right terminology and understand what happens in different situations. So we often interchange the use of fever or pyrexia and hyperthermia. And there's actually something that happens differently when I have a patient who has a fever or pyrexia. So that's the result of that systemic threat, whether it's an infection or an injury, and the stimulus that goes to the hypothalamus to reset the temperature. Now, one of the things, and I know Lori may talk a little bit about it. I know she's going to be looking at this in the future because she's going to lead a group with Neurocritical Care Society to develop some guidelines about temperature management. And one of the controversies is, what is a fever? What's the number that defines a fever? Well, the Society of Critical Care Medicine says 38.3. But if you look at the literature, there's really a wide range of temperatures that are labeled as fever or pyrexia. Now, hypothermia is a temperature above normal. So technically, hyperthermia is a fever. However, true hyperthermia is a result of being exposed to an external environment that heats up the body. And there is not a change in the set point. So you're outside exercising on a hot day and you sweat and you're not drinking enough, you can become hyperthermic. So we think about heat stroke. Now, that is different because of that fact that the hypothalamus does not change its set point. Now, there is one more fever that we talk about, and that's neurogenic fever, also called central fever or post-traumatic hyperthermia. And this is a direct injury to the hypothalamus, where in this case, there is not the perceived threat, but there is a reset of the set point. And I'll talk very briefly because when we are trying to change the patient's temperature, if it is an injury to the hypothalamus, our traditional medications in particular don't work. So what are the causes of fever? You all really know this, but the biggest thing to think about, we always know, is we think first, is there an infection going on? So most common infections that we see in the hospital are pneumonia and urinary tract infections. Then non-infectious causes of fever are related to drug and transfusion reactions, deep vein thrombosis, and then the other non-infectious is that neurogenic temperature. So when we're thinking of these things, again, we're either thinking of a direct injury if it's the neurogenic hyperthermia, or an inflammatory response. If we have a hyperthermic syndrome, it's the heat stroke and malignant hypothermia, and I'm not going to really talk about that. So we're going to focus on brain injury, but a fever, an elevated temperature, even in a healthy person, can be bad. But we know that a moderate response to a threat, an infection, is an indicator that we have a good immune system. Our body is responding appropriately. But if our temperature starts to go above 40, we start to have a problem, even in an uninjured patient, a non-neuro patient. So at 40, we start to see altered level of consciousness, some altered brain function. And at 43, we actually will start to see neuronal injury. One of the things to remember is that for every degree centigrade change in temperature, whether it's up or down, there's a change in metabolism. So if the temperature goes up, it's somewhere around 10%, and I've seen everything in the literature from 4 to 15. So 10's kind of the middle ground and easy to think. And we know that if we increase the metabolism, that patient at 43, that's 40% increase in the demand of the tissues. This is where those patients have the potential to be oxygen-starved, hypoxia, and in many cases will develop seizures. So where should we measure temperature? And I actually think we have a lot of options now. I remember way back when I first started, we had glass thermometers, and that was about it. And through the years, we've got all kinds of probes and that. So we can now measure the temperature peripherally, or we can measure it in the core. And we're going to talk a lot more. Our goal is core. That's really what we want to know. And ideally, in many of our patients, we want brain temperature. So the peripheral temperatures are unreliable because there are a lot of external environmental factors that can affect it. So you heard Christy say, I go to Africa. The only thing they use is axillary temperatures, which makes me crazy. And I watch how people are measuring, at least now our electronic thermometers kind of tell us when we're cooked and it's reading, versus the old thermometers, well, it was up to you, how long you kept it there and how accurate you really were. And the core is really giving us the example of what the temperature is in these core organs, the brain and the organs in the thoraco-abdominal cavity. And although they can also have some influences from internal and external factors, they're less significant. So I put this together of all the technologies that are out there. And so there are a lot of places that we can measure. And I think there's one thing notice I crossed out the mercury. Why? Because we don't see that, but I hate to say mercury thermometers are still out there in some of the areas, which is scary. So when you look at the literature, we often use some of these peripheral thermometers, but they're not the most accurate. So here's an example of some of the literature that's out there looking at the accuracy of different places. Not everything. You can see I've kind of highlighted in blue the ones talking about what is equivalent to core. So basically you've got rectal and you've got bladder temperatures that are commonly used. But then the core, our PA pressure is really sort of the gold standard everybody's looking at, esophageal. But tympanic and oral, the oral chemical are the ones with the little dots, the little paper ones that you can throw away. That's what they're talking about. Not very good. Tympanic, again, you can see two of them say tympanic. I like this last one here. They say actually the gallium in glass temperature, or axillary temperature, is pretty accurate if you leave it there for 12 minutes. So, the reality is we want the most accurate reading. So about a year ago, a group from the Neurocritical Care Society did a multimodality consensus conference and developed statements about different ways to monitor our patients. And one of the things that they did was they recommend that we use continuous temperature management. How many of you use continuous temperature management? So, some. Okay. So continuous temperature, and that I think it's more common in the ICUs to use the continuous temperature management, and that if not, you should do that hourly, take the temperatures hourly, and that the best place to monitor is the brain, because that's the part we're worried about, and if not, then we need a core temperature. So probably one of the most common ones I see without having invasive catheters such as our PA catheters is bladder, because everybody's got a Foley. So why is it we keep saying the brain temperature is key? So the brain temperature is critical because it is actually hotter than normally, is going to be a little bit hotter than the core. And if you look at the literature, there's a wide range of numbers out there. And if you say about a half a degree to a degree is probably, at least you have a sense of how much normally you would see in variation between the core and the brain. And it varies. It's going to widen or get greater difference when we have a fever or when we induce hypothermia. So both times when we really need it. So why is it? Well, it's because our brain gets blood and heated blood from the systemic organs. We produce our own energy and heat, and it's related in part to the patient's cerebral blood flow. So if 50 is a normal cerebral blood flow, averaging across all tissues, and around 18 to 20 is ischemia, as long as we have adequate flow above ischemic levels, then the brain temperature is typically going to be higher than the body's temperature. But if we have ischemia, we start to see a reversal. And there's actually been a couple of studies that suggest that once you have that crisscross and it keeps going down, and if you don't do anything, you have about 4 hours before they hit brain death. It's kind of an interesting note. And then the other piece that really is what makes the difference in this temperature is the fact that we are all hard-headed as we get older. So as we age, our skull gets thicker and it insulates the brain. So if you think about the babies, skull's very thin when they're born. We've got open fontanelles. I always say sort of air conditioning, kind of like what we do to the patients who have decompressive craniectomies, where we open things up. And so their temperature variation is not as great. That's, if you think, when babies are born, what do? We cover their heads because they lose heat from their brain. Hyperthermia, what does that do to the brain? Well, it increases the excitatory neurotransmitters and oxygen-free radicals, disrupts the blood-brain barrier, and it impairs the recovery of energy metabolism. When we have hyperthermia, we have an increase in metabolic demand. What the brain's going to do is try to meet that demand by increasing cerebral blood flow. So the vessels dilate. That means we end up with increased cerebral blood volume, which leads to increased intracranial pressure. So we talked about what happens when we have injury. And if you remember, if you look at the top line here about the pathophysiology of hypothermia and where hypothermia works. The other areas here are also things that we have talked about with reperfusion, the fact that hypothermia happens to dampen a lot of these effects. So it's why people are really interested in, if I treat my patients with hypothermia, I may decrease that secondary injury. So there's more than 100 years of experimental and clinical data talking about targeted temperature management. Historically, therapeutic hypothermia was thought to be used to decrease the metabolic demand and put the brain to rest. Now, we look at it as more as a neuroprotectant, both in a variety of situations that are focal or global injuries. And these are just a list of some of them that we looked at with targeted temperature management. Cardiac arrest probably has the most robust and current research data. Traumatic brain injury, spine, stroke. Also, one area that we're not going to really focus on, but has a lot of information, is the neonatal ischemic encephalopathy. And this is just a text that I'm going to kind of lead you into Lori's talk, and that is a quick summary of where we are with some of the research. And I've highlighted the places where we have pretty good data to say it works, is helpful in cardiac arrest, and is helpful to control increased intracranial pressure. There is variable data on all these other categories with stroke, with traumatic brain injury as a neuroprotectant. So we still have a long way to go. But I'm going to turn you over to Dr. Madden, and she's going to talk about the impact of the body temperature on neurologic outcomes in traumatic brain injury, but she'll also give you a little more background.